2009, Susan was recognized by the Arthritis Association as Volunteer of the Year. In 2012, she received the Dorothy B. Kaufman Professorship Award from the Hand Foundation of Philadelphia. Dr. Stralka, welcome to the program. We are now ready to begin.
Thank you. Today I'm going to be talking about both musculoskeletal as well as neurovascular consequences of injury, and we're going to identify ways to retrain the brain to increase movement as well as improve function for someone that doesn't want to move, who fears they can't move, or has kinesiophobia. So we must start now by thinking that pain, as we once thought, is a sensory sensation, really isn't true. Pain is an output of the brain. So we now know that it's the brain that interprets pain, and the brain's job is to protect us, and it determines if the pain is present, and if it is there an action required? So in dealing with graded motor imagery, we have to remember that since we're dealing with the brain, that we need to use a biophysical social approach because the pain experience is not hardwired. And what I mean by that, pain is more complex than the traditional way that we once learned pain. So according to Mosley, pain is a multi-system output. It's activated by a specific neuromatrix in the brain. That means areas that are connected together. The neuromatrix is activated when the brain concludes it's in danger and action is required. So we'll be talking about this type of pain today, and it is the new neuroscience evidence on pain. As I stated, pain is very complex because it involves both the peripheral and central nervous system. I know that as clinicians, we all are good at treating peripheral symptoms, but we've got to talk a little bit now about the central system because we know that pain is an output, obviously, of the central nervous system. And as clinicians, we're going to differentiate, are there peripheral symptoms or are there central, and how can we treat them? So we know that both the peripheral and central nervous system are involved. So when we speak about the central nervous system, if you look at this slide, you will see we're talking about the dorsal horn of the spinal cord, ascending pathways, specific areas of the brain, as well as descending pathways can be changed when we have central sensitization. So we've got to talk about these pain mechanisms and decide what our patient has. Do they have nociceptive pain, which is the typical pain that when you sprain your ankle or sprain your wrist? Do they have the peripheral neuropathic pain, basically, which means that it could be a systemic disorder like shingles or diabetes? And neurogenic pain, peripheral neurogenic pain, is just typical nerve pain. But here is the new information, central sensitization. How do we know that our patients have central sensitization? And if they do have central sensitization, we must remember that there are changes in the brain.